So in the next 25 minutes, I'd like to cover the different aspects of renal replacement therapy, which essentially is a type of treatment which may be necessary for some patients with severe acute kidney injury. And like any other therapy, there are different aspects which need to be considered when essentially prescribing this treatment. In this talk, I want to focus on three aspects. Firstly, the indication. Secondly, the timing. And thirdly, the dose. So starting off with the indication, when making a decision whether treatment is necessary or not, then it's obviously important to review the benefits and the risks of this treatment. And essentially, with renal replacement therapy for acute kidney injury, we are trying to replace the problems or replace what the deficiencies in acute kidney injury. So we are trying to ameliorate fluid overload by removing fluid during this treatment. We are trying to remove uremic toxins, and we essentially try to restore some metabolic hemostasis. There is also some suggestion that we may modulate the immune system and immune milieu, but the evidence for this is still quite vague and a little bit controversial. In the intensive care unit, the most common types of renal replacement therapy are continuous renal replacement therapies, of which there are three as listed here. So it's either continuous hemodialysis, continuous hemofiltration, or a mixture of both. As you can see on the slide, I've also mentioned peritoneal dialysis on my slide because strictly it's also a type of continuous renal replacement therapy, which in fairness is not often used in the acute setting in the UK and in Europe. But it's a type of renal replacement therapy which has an important role in other countries, for instance, Africa and South America. But for the purpose of this talk, I want to focus on practice in Europe and in the UK. I will not mention peritoneal dialysis from now on. In contrast to continuous treatments, there are intermittent modalities. And again, as listed here, there are different ones, but they all vary really only in their extent, in their duration. So there's the classic intermittent hemodialysis, which is classically 4 hours every other day, sometimes every day. And then there are prolonged types of intermittent hemodialysis, where essentially hemodialysis is provided for 6, 8, 10, or up to 12 hours. And they're called, have been named differently, either slow extended dialysis, so SLED, or most recently people have called it PERT, which is prolonged intermittent renal replacement therapy, but essentially both are the same. If you add a little bit of hemofiltration to the intermittent dialysis, then it's called SLED-F, so SLED plus hemofiltration. But essentially, these 4 different types of intermittent hemodialysis are all the same, and they only differ in their duration. The question is whether one is better than the other. So is intermittent hemodialysis as good as continuous hemodialysis or continuous hemofiltration? And there are certainly numerous studies in the literature supporting either one or the other. And there will be numerous studies supporting your individual practice. And as you can see here in this meta-analysis by Sean Bagshaw, when you look at all these different studies and compare them and summarize all the results, the overall result shows no difference. And this is essentially studies looking at mortality. So if we focus on mortality alone, there is no difference between continuous renal replacement therapy versus intermittent hemodialysis in the acute setting. This does not mean that the individual patient may benefit from one more than the other. So for the individual patient, it may be the case that he or she is most suited to have to receive one treatment over the other. That's why it's important to remember that these different types of renal replacement therapy have their own advantages and disadvantages. So continuous renal replacement therapy, as the name says, continuous mode to remove fluid and to clear toxins, is particularly advantageous in people who are hemodynamically unstable. So the people who have fluctuating blood pressures, who may be on treatment to support their blood pressure, who have a precarious fluid state and don't tolerate fluid removal very well. For this group of patients, a continuous mode is undoubtedly better. Better in the sense that they tolerate it better without fluctuations in their blood pressure and overall cardiovascular condition. There's also evidence that patients with brain edema, with cerebral edema, tolerate continuous renal replacement therapy better, or the other way around. They don't tolerate intermittent hemodialysis very well. They don't tolerate these fluctuations in fluid accumulation. And for patients with liver failure, the same applies. Continuous renal replacement therapy seems to be advantageous. In contrast, patients who are better, who are already recovering, who are rehabilitating, who've passed the critical illness, for this group of patients, it's obviously important to focus on recovery, rehabilitation, physiotherapy. And for this group of patients, an intermittent mode may actually be better, an intermittent mode which allows them to have physiotherapy in between, to mobilize without being confined to their bed, which they would be with continuous renal replacement therapy. So in conclusion, strictly there is no difference in terms of mortality between a continuous mode versus intermittent hemodialysis. There is no evidence that one mode is associated with a survival benefit. However, both therapies have their own advantages and disadvantages, and the key thing is to find the right type of renal replacement therapy for the individual patient. So once a decision has been made that a type of renal replacement therapy may be best suited for the patient, the question is when to start. There is essentially no clear indication, or there's no best time when to start renal replacement therapy. And there are proponents of an earlier start, and there are some people who propose to leave renal replacement therapy until it's absolutely necessary. And both groups will have their arguments and evidence to support their opinion. There is no doubt renal replacement therapy is beneficial, but associated with side effects. And the side effects are well known. They relate to line insertion, they relate to the fact that these lines get infected, the lines can bleed, the line insertion can be associated with complications. So people who propose to wait with renal replacement therapy until it's absolutely necessary, they will say, well, renal replacement therapy has complications and I only start it if it's absolutely necessary. They will also argue that renal replacement therapy should only be started when it's absolutely necessary, so that patients have a chance for their kidneys to recover on their own. And finally, there's no doubt that renal replacement therapy is very expensive, and therefore to start renal replacement therapy unnecessarily when it may not be necessary is associated with increased costs. People on the other side of the argument who start renal replacement therapy earlier will argue that they don't want to leave it until it's absolutely necessary. They don't want to put the patient at risk of potential uremic complications. And they will argue that it may be better to maintain homeostatic or maintain some metabolic homeostasis where patients don't get very fluid overloaded and where the toxin levels don't get into a very dangerous range. And so they would start still when fluid balance and metabolic derangements are still in a controllable area. So we have proponents and people supporting both sides of the camp. If you go to the literature, it's very difficult to find evidence for one or the other. There are numerous studies looking at timing of renal replacement therapy. In these studies in the literature, the individual investigators have used different ways of describing the right time. Some people have used urea, which is obviously one of the waste products in the body, which accumulates in renal failure. And they've looked at different types of urea as a trigger to start renal replacement therapy. Others have used creatinine level to trigger renal replacement therapy. And some studies have looked at the time between admission to ICU and the day of renal replacement therapy. Like many studies in the field of renal replacement therapy in ICU, the evidence is very conflicting. There are, at present, only 2 randomized controlled trials in published version, and the rest of the data stems from observational studies. The majority of studies seem to favor early renal replacement therapy. However, if we focus on the 2 randomized controlled trials alone, the important one is this by Catherine Bowman from Amsterdam, where she essentially randomized 106 very sick patients after heart surgery predominantly to 3 different timings of continuous hemofiltration. She combined this project with a project looking at different doses. And so essentially patients were randomized to early high volume hemofiltration versus early low volume hemofiltration compared to late volume hemofiltration. Now, for the purpose of this presentation, I obviously want to focus on the timing. So we have 3 groups, of which 2 started very early and 1 group started very late. And interestingly, in this group of very sick patients who all had significant multi-organ failure, there was no difference in 28-day survival between patients who had started renal replacement therapy early compared to those who started late. When they added another outcome, in this case renal recovery, again there was no difference. So this was done because some people feel that a late start, so starting renal replacement therapy when it's absolutely necessary, gives the kidneys a chance to recover. And they would say that if you started too early, you take the chance away for the kidneys to recover spontaneously. In this largest randomized controlled trial, which we have to date, there was no difference in renal recovery between the 2 groups, between the 2 time points. There is a second randomized controlled trial, and again, these are the only 2 in the literature, which looked at a much smaller population of only 28 patients. They all had renal failure after cardiac surgery. And in this group, the patients who had started renal replacement therapy earlier did better. As you can see here, they had a significantly lower mortality at 2 weeks. And obviously the authors of this paper argued that an early start of renal replacement therapy after cardiac surgery was beneficial. So the only 2 randomized controlled areas in this field showed conflicting results, but admittedly they were done in different patient populations. The rest of the data stems from observational data where people look back at their own practice. And just as an example, I've got the results of 3 studies here, where you can see that the authors in these 3 studies looked at urea level. So they used the urea level in the blood as a marker of severity of renal failure. And in these 3 studies, patients who had a lower urea level, so they had less urea accumulation at time of renal replacement therapy, had a better outcome. So less patients died during their stay in hospital. Clearly, these studies would argue that renal replacement therapy should be started as early as possible in order to improve the chances of recovery and survival. In contrast, a much bigger study from multiple centers in multiple countries showed the opposite. With regards to urea, they found no difference, independent of whether you started renal replacement therapy was started with a higher or lower urea level, made no difference. But when they looked at a different marker, for instance creatinine, they found that those patients who had started renal replacement therapy with a significantly lower serum creatinine value had a much higher mortality. So conflicting results just in these 4 studies, but we've got 11 other observational studies, 15 in total. As I already said, the majority concluded that earlier was better than late, but they were all done as retrospective data analysis. There was no clear indication about their severity of illness. And the critics have pointed out that a lot of patients in the late arm received renal replacement therapy far too late, when the toxins had already accumulated to dangerous levels. And on the other side, in the earlier arm, patients were included who actually had already recovered renal function and probably didn't need it anymore. So very conflicting messages in the literature at the moment. Together with colleagues, I looked at a large database of 4,200 patients, which included 1,100 patients on renal replacement therapy. In our data analysis, we found that it wasn't the typical classic renal factors which were associated with a poor outcome, but other non-renal factors, in particular associated organ failure. So patients who had associated respiratory failure and were on the ventilator, patients with hematologic bone marrow failure, people with gut failure who needed TPN. These were the patients who had a significantly higher risk of dying compared to patients without these risk factors at time of renal replacement therapy. We also found that urine output was very important, and patients who were still passing urine at the time when renal replacement therapy was started did much better compared to those who were already anuric. So in our study, we concluded that the classic renal parameters did not determine outcome of renal replacement therapy, but it was all the other factors, the other non-renal comorbidities. I've already alluded to the importance of urine output. This was certainly supported by data from the PICARD study, where they looked at fluid accumulation at time of renal replacement therapy. And they found, as shown in the graph here, that patients who were very fluid overloaded at time of starting renal replacement therapy had a much higher risk of dying. So again, not the classic uremic toxins which determined the outcome, but the severity of fluid gain and associated organ dysfunction. Clearly, people who have accumulated more fluid will undoubtedly have more problems with their breathing and have other non-renal organ dysfunctions. So based on these findings in these different studies, colleagues and I would propose that the decision when to start renal replacement therapy should not depend on the individual urea or creatinine values, but on other non-renal markers and essentially the general condition of the patient. So when assessing a patient with acute kidney injury, the first question is obviously whether they are in immediate danger. So in case of any uremic emergencies, there is no question and renal replacement therapy is obviously indicated. But if they're not in immediate danger, and there are no uremic emergencies present, then there is time for resuscitation. And the important thing is obviously to resuscitate blood pressure and volume status. And again, the most important thing is to not only start resuscitation, but to go back and reassess the response. And patients who respond and slowly get better and have a resolution of their general illness don't need renal replacement therapy, usually don't need renal replacement therapy, independent of the urea and creatinine value. In contrast, patients who continue to deteriorate and don't respond to resuscitation and develop other non-renal organ dysfunction, in particular pulmonary edema, severe acidosis, or stop passing urine and get more fluid overloaded, they should be started on renal replacement therapy. And they should probably be started before they develop any of these uremic emergencies. So once a decision has been made that renal replacement therapy should be started for whatever reason, and the decision has been made which type of renal replacement therapy should be started, obviously depending on the patient's individual characteristics, the next crucial question is how much. And until a long time ago, until 10 years ago, we didn't really pay that much attention to dose. But it's clear certainly from my experience in end-stage renal failure, that dose of renal replacement therapy is important. The classic parameters to describe dose, as we know from chronic dialysis, is KT over V. But this calculation is not valid in the acute setting. So people have looked at other ways of describing dose in patients with acute kidney injury. And classically, they've either looked at the frequency of intermittent renal replacement therapy or at the volume of filtrate used. And it was Claudio Ronco who alluded us in 2000 and at the end of 2000 that dose may actually be important. And he was the one who highlighted that, like any other therapies, like antibiotics or drugs, hemofiltration or any type of renal replacement therapy should be dosed according to patient's body weight. And in his landmark study, as we all know from the publication in The Lancet, he found that sick patients who'd received a higher dose of hemofiltration had a much better outcome. So this was such an important study that a lot of subsequent guidelines essentially followed this included this recommendation. And the main conclusion was that people who didn't need a renal replacement therapy and didn't get enough renal replacement therapy had a much higher risk of dying. And secondly, he alluded to the fact that renal replacement therapy needed to be individualized and that different people needed different doses. Although it was a landmark study, it was clear that some people were concerned about some issues in the study. For instance, the fact that it didn't include many sepsis patients. Only 17% of patients had sepsis. That's very unusual for for ICUs. It was criticized that it was a single center study. And people were concerned that these results may not apply to all ICUs. And correctly, other units, investigators tried to repeat the studies and tried to repeat the results. In a large multi-center study done in the US, called the ATN study, 1,124 patients, ICU patients with acute kidney injury, were essentially randomized to 2 different doses of renal replacement therapy. Now, practice in the US is different from Europe in the sense that in the US they use a lot more intermittent renal replacement therapy. And to make the study doable, the investigators decided to allow practitioners to use either an intermittent mode or a continuous mode. And as a result, we have a very mixed bag of different types and different doses. And so patients essentially were randomized to a higher dose versus a lower dose, and were also randomized at the same time to different types of treatment, depending on the practice in the unit. So it's not strictly a dose study, but ultimately it did compare two different doses, a higher dose versus a lower dose. In this study, the investigators also lumped hemodialysis 6 times a week with hemofiltration at 35 mL per kilo per hour. And this is not necessarily the same. However, in this study, which was a very important study, unlike the previous landmark study, the investigators found no difference between patients who had received a lot of renal replacement therapy compared to those who had received far less. I've already alluded to this. The study got again criticized by quite a lot of people. And it was criticized because there were no clear criteria when to start renal replacement therapy. It was obvious that some patients in the lower dose group hadn't received enough and needed rescue renal replacement therapy. And the study's also been criticized for this mixture of dose and type of modality. And therefore, not surprisingly, people were looking forward to a similar study which was performed in Australia and New Zealand, where the investigators just looked at one modality and compared two different doses. And in this study, in 1,500 patients, all patients received one mode, in this case continuous hemodiafiltration, and they were randomized to two different doses. And although it was done slightly differently from the US study, again, in this large multi-center study, there was no difference in terms of mortality between patients who received a higher dose of renal replacement therapy versus a lower dose. So at the moment, although the study from Claudio Ronco had suggested that more renal replacement therapy may be better, subsequent multi-center trials in much larger patient populations with different comorbidities were unable to replicate these results. There is still some suggestion by some people that patients with septic shock may need more. And they may need more hemofiltration because we know that various cytokines produced in sepsis get cleared. We know that these cytokines, which classically accumulate during sepsis and pro-inflammatory states, have a molecular weight which is below the cutoff of our membranes. And so a lot of people are still waiting for the final results of the IVOR study, which was done in Belgium and France, where they looked at a higher dose of hemofiltration in patients with sepsis. The hypothesis being that hemofiltration at high rate is good and beneficial. Although the publication is still awaited, the preliminary results are out and show no difference in mortality. So the question is there an optimal dose for renal replacement therapy? We know now, we've learned in the last 5 to 10 years, that more renal replacement therapy is not necessarily better than less. So we can't improve mortality by giving extra renal replacement therapy. But is there a minimum dose? Can we go as low as we absolutely have to? And there is currently, by consensus, the opinion that the minimum dose of renal replacement therapy is probably around 25 mL per kilo. Although some of the studies, in particular the study from the US, showed that 20 mL per kilo was as good as 35 mL per kilo, people are concerned that 20 mL per kilo per hour for the average patient may not be enough, because it may not take into account that there are interruptions in treatment. And we know from quite a lot of studies now that a lot of patients in the ICU have interruptions in their treatment, where we have prescribed a dose, but for some reason patients don't receive it because they may have unexpected trips to the scanner, they may have unexpected trips to theatre, the lines may clot, the circuit may block, and the renal replacement therapy machine may not work, and the treatment has to be stopped. So in order to make sure that no patients are under-dialyzed, the consensus opinion is that patients should receive at least 25 mL per kilo per hour. And the consensus opinion is that a higher dose is not necessarily needed in order to improve mortality. It's very clear that doses, the whole prescription, in particular dose, needs to be reviewed on a regular basis. And not only the dose, but also the therapy provided. And it's important to look back and see whether the patient has actually received what was prescribed. And if not, to make up and adjust the dose accordingly. So like any other therapy, renal replacement therapy needs to be reviewed on a regular basis and adjusted according to the patient needs. Finally, to conclude the slides on dosing, it's important to acknowledge that flexible dosing has never been studied. So no study has looked at adjusting the dose according to patient's need and being flexible. In all these studies, patients received one dose right from the beginning till the end of their stay in ICU. But no study has, what we commonly do with other therapies, adjusted and maybe given more in the beginning and less at the end. And this brings me to my final slide, where I essentially want to emphasize that renal replacement therapy in the ICU is a treatment which, like any other treatment in hospital, needs to be prescribed properly, and the dose and the mode need to be reviewed on a regular basis and adjusted. There are clear reasons why we may need it, and the obvious reasons are to essentially replace renal function and to provide some help to the body in terms of providing organ support. The decision when to start should not necessarily depend on the individual renal markers, but on the overall condition of the patient. And in patients who are deteriorating with progressive fluid accumulation, with progressive organ dysfunction, it should be started earlier, as opposed to in contrast to patients who are generally getting better and are increasingly passing urine and are on the road to recovery. Those patients don't need it even if the renal markers are raised. And finally, with regards to dose, there is currently no evidence that more is better, but it's clear that there is a minimum dose, and the minimum dose is probably around 20 mL, but to be on the safe side, we would recommend 25 mL per kilo per hour. Thank you very much.